Afternoon, everyone. This is Dr. Bilal, PGY3 Internal Medicine in AdventHealth Tampa. I just wanted to confirm with AdventHealth Wesley Chapel. Can you hear me?
We can hear you at Wesley Chapel.
Okay, sounds good. Okay, thank you. All right. So today my presentation is chest pain for intern bootcamp. And the reason I'm presenting this topic is that we cannot deny or we can ignore this chest pain. And the reason I would mention is why it's important in the next few slides. So first thing is what are the learning objectives for today's presentation or noon conference? I would say, first of all, we have to recognize what are the common life-threatening conditions that can present as chest pain. There are common six conditions that we have to rule out. The second thing is that we have to get a focused history and physical exam, and that will help us in identifying the reason for the chest pain. And next is what to do next, which is very often when you hear chest pain, you don't know what to order. So in this lecture, we will try to teach you what to order and what is the right manner to order it, maybe EKGs and other investigations. Okay. And the last part is management, which is very important. And also, we have to decide whether this patient is going home, admitting under observation, or to the unit, which is maybe PCU, med surg, ICU, depending. Okay. So epidemiology. So I was looking and 6 to 8 million presentations in the ED are because of the chest pain. So it is very common presentation, a symptom you can say. So you will deal it with maybe if you are in the ED 2-3 times daily. If you are working inpatient, maybe every other day, twice a week. I know pain is very common, and last 2 weeks you must have heard pain daily, and you treat with Toradol, Tylenol, and Percocet. But when it comes to chest pain, you cannot just order Tylenol or something. You have to do workup. The other thing is that ACS is not very common, but again, we have to rule out the ACS. And most of you can say 10 to 15% presentations are because of the ACS, which is acute coronary syndrome. And I would tell you what conditions come under this ACS term. Okay. Early recognition is very important to decrease, or you can say to avoid severe morbidity or mortality. When it comes to cost, you can see 13 to 15 billions, they say, annually is spent on the ED chest pain presentation. Okay. I won't say that you can focus on the cost part. I would say focus on the right way to diagnose the condition and to treat it. We don't have to randomly put orders echo, CT, all these things without following a proper you can say algorithm. Okay. So how do we describe chest pain? Chest pain is, according to AHA, they say any unpleasant or uncomfortable sensation in the anterior chest. And it can have different terms depending on the patient literacy and cultural, it depends on a lot of factors. Okay. Some people will say pressure, tightness, squeezing, heaviness, burning sensation, or maybe say it's tearing, or maybe oh, it's just discomfort, it's just hurting. So a lot of words. Okay. But commonly you will see pressure, tightness, squeezing, heaviness, gripping. All these are the common, way to say, or how to represent with it in the ED or in the hospital. We don't usually say it it's atypical or typical. We now describe chest pain as cardiac, possibly cardiac or non-cardiac. Okay, these are the right terms to use. We don't use the typical and atypical chest pains. So, okay, history. History is very important, and especially I think you will hear this a lot from Dr. KB in next few years. She history is very important, and I would agree with her. It helps a lot in the diagnosis. of most of the conditions based on history and the vitals and the common things. Okay. So age is very important. So if there is like a young person younger than 40 or 35 years presenting with chest pain, the differentials will be different. If it's between like maybe 40 to 60 or 40 to 70, we usually think of like chest pain is because maybe MI is contributing to this, maybe some aortic dissection, pulmonary embolism, all these things. So the differentials change with the age. So we have to like know like what is the patient age, which is very important. The second thing is nature. So nature is like described again. Some people say pressure like tightness, heaviness, these symptoms. Some people say they present with the chest pain and say like it's like burning or maybe acid reflex like. Some people say like it's tearing, stabbing, all these, they're like different. So we have to specify what is like the nature of the pain. Okay. The third thing is that we have to ask onset and duration. So when did the pain start? So yeah,
I would just like to share like an outlier case. However, there are outliers for age
yeah,
as it relates to risk factors for which they have no control, like genetics,
yeah,
ethnicity,
definitely.
major comorbidities like diabetes. Because it's not uncommon to see 35-year-olds with blockage because of certain risk factors or lifestyle
That's
factors.
that was I like my plan was to discuss that later because if the patient has like a history of premature like CAD, which is cardio like coronary artery disease in the family, or maybe some other conditions in the family, then everything changes. For example, hyperlipidemia, hypertriglyceridemia, these can change the whole scenario. Okay. So, and I will discuss that in the next slide, like why it is important. So, onset and duration, usually the myocardial infarction, for example, it doesn't like present for 3, 4, 5 seconds or 10 seconds. It gradually happens in few minutes and then increases, right? Like 30 minutes, 1 hour presentation, something like that. While it's like if you see the maybe acid reflux, it will be there for many months, okay, and changes with the duration changes. It can happen with the food, it can improve with the food, like worsen with the food, all these things. So it is very important to know when did the pain start and what is the duration, okay. And we have like some examples later on that will signify why the duration is very important in history. Location and radiation. Again, what do you guys think? How does like the MI usually present? What is like the most common, symptom? How does it say like where's the patient? Is it like
Mid chest, right external,
okay?
irradiation to right left arm, jaw, neck,
Yeah, very good.
scapula.
As I said, like mid chest radiates to the like neck or arm, which is very common. What about like aortic dissection? What do you guys think? Tearing, yeah, tearing. It's going to the bag radiation. So this is very important. What do you guys think of like maybe acid reflux? How does it present? Okay. Okay. And what about like maybe pulmonary embolism? Sharp, like pleuritic like presentation. So it's very important. Like it's and then what about like costochondritis? What do you guys think?
Reducible.
Yeah. Okay. So these are like very important. Like where's the location? Okay. It can be like costochondritis can be located in the like anywhere in the chest. Okay. If you look at the gallbladder, like cholecystitis, where does it usually like in the chest or arms? Where does it present the pain? Right shoulder. So you can like when you ask about like the location and radiation, it can tell you a lot of things. Okay. Severity.
And what about pericarditis? The classic pericarditis pain, they will tell you what it gets better with.
Very forward, yeah. So again, so these are like a common things. Again, that will be like more in the precipitating factors or relieving factors we will discuss. Severity is also very important. Like most like commonly it presents like like squeezing pain. They usually say 7, 8/10, maybe 10/10, but it can be also like in patients who are elderly, diabetes, or women, it can present differently. It can be like a silent MI they used to say. Okay, it can be associated like it can present slight pain with vomiting, maybe some, discomfort. So we have to be very careful with this, like severity part. Precipitating factors are very important. What do you guys think of MI? Will it worsen with the activity or will it improve with the activity? What do you guys think? Worsen. Okay, yeah. So these are like very common things that happen, especially with the angina. It worsens. So we have to know what are the precipitating factors. Again, if you are eating and that is worsening the pain, it's likely because of the GERD, right? So we should know about these things. So we have to ask these things. Relieving factors. If I say that I gave Toradol to someone who presented a young guy with pain in the center or in the chest, which is reproducible with the palpation, and I gave Toradol maybe. What do you think? What was the most likely cause? Yeah, but if it's like pain that improves with the nitroglycerin, what do you guys think? MI, right? Myocardial infarction. So it is very important. What are the relieving factors? Again, if it improves with the rest, most likely it is likely because of the demand thing, right? So if there's not a lot of demand, it is that the function is improving. Okay.
And remember, esophageal spasms also improve with nitroglycerin, so that could throw a wrench in your differential.
Yeah. Again, they're like
You put everything
outliers.
together.
Yeah. So associated symptoms. What are the common associated symptoms that you can see? Diaphoresis, but that is common with the MI because. But imagine like if the patient comes to the ED, they say like I have chest pain. When you ask, they say like I have multiple episodes of vomiting. And now I have like chest like now I have like chest pain or upper abdominal pain. What do you guys think? What is the most common reason? It's because of the vomiting, right? So you have to be careful, like what are the other symptoms? Maybe, for example, sweating, tachycardia. These are commonly associated with the cardiac, like myocardial infarction. If you look for the oxygen part, like decrease in saturation, tachycardia. What is the most common? PE, pulmonary embolism. So we have to look for those symptoms too. Okay. Okay, next part in the history is past medical history. It is very important. And when I say this, because what are the most common, conditions or like comorbidities that are present in the myocardial infarction? What do you guys think?
Hypertension, hyperlipidemia, diabetes.
Okay, so diabetes, hypertension, hyperlipidemia, it is very common. Okay, what if I say like the patient has like a I will mention that in the family history. If the patient has like a family history of some connective tissue disorder, and the patient is complaining of chest pain, what do you guys think? Dissection, right? Maybe Marfan, maybe some other condition. Okay, so family history is also very important. Again, hereditary hyperlipidemia is very important. You have to know any other conditions like in the family, for example, premature, cardio like CAD that we discussed. So we have to know about that part. So it should be very detailed, past medical history, family history. Why do you guys think surgical history is important? Recent surgery. Okay. So imagine if the patient has history of device implant, maybe pacemaker, maybe something like ICD, and now the patient is complaining of chest pain. Okay. So again, you have to rule out the maybe MI, but you also look whether there is like some infection going on, which is very also important. Okay. So surgical history is also very important. Patient can have like cabbage, patient can have like some other conditions, like maybe in female, they have like recent procedure for the breast tumor or something, now presenting with a chest pain, maybe this like mastitis compared like, and we are thinking of MI. So we have to be like aware of what is happening. Okay.
And also with recent surgical history, they'll be at risk for the as well.
Yeah.
So gotta keep that in your record.
Yeah, then so depending on like how like whether the patient was hospitalized, like admitted for 2, 3, 4 days, depending on the immobilization criteria. The other thing is social history. What are the most common things we look in the social history? Smoking,
Drugs.
alcohol, drugs, for example,
Okay.
cocaine, like sympathomimetics, like cocaine and methamphetamine. If the patient is presenting with that, can be like because of the vasospasm of the like coronary artery. Could also be because of like it can cause high blood pressure, maybe injury to the aorta or descending aorta. Okay, so it's very important. Okay, again, the patient has cannabinoid history. Maybe the patient has like hyperemesis syndrome. So it's like you have to ask all these um, questions regarding social history, surgical, and all these things. Okay, so again, this is a picture I got from AHA, and it can tell you the probability of ischemia based on the symptoms nature. If you look at like central pressure, squeezing, gripping, tightness, retrosternal, all these are like most likely related with the ischemia. But we have to like also keep in mind that the patient have that like age group, have those risk factors now presenting with these things. So we should be very aware of the possible ischemia. Okay. If it's like a sharp, fleeting, pleuritic, positional, usually the MI pain does not change with the positions. Okay. So if it's happening, so you can also think other things in the differential. Okay. So this is very helpful table. I know it's like a lot of words, but as you do your residency, you will see it. It's like easy to get the history from. Okay. What is the next most important thing after history? Physical exam. Okay. So first thing is vitals. Why vitals are important?
Stable, unstable.
Huh? Stable and unstable. Okay, good. What else?
Oxygen saturation.
Oxygen saturation comes again. PE can cause that. Even it can happen with MI. So you have to be careful about that part. What about like blood pressure variation? It can happen, right? If you do like in both arms, it happens when dissection. Okay. So what about fever? If the patient has hyperthermia, maybe hypothermia, what do you guys think?
Endocarditis.
Could be infection, right? So fevers is happening, and respiratory rate again. It usually happens when the patient has like pneumonia, COPD exacerbation, maybe PE. So vitals are very important. Okay. And again, you can do like maybe repeat vitals just to see how things are going. Okay. And it is very important to understand that you should take vitals in the right way. So usually like when the patient is standing, sometimes they are like, cross legs, all these things. So you have to be also careful about these parts, especially in the clinic and also in the hospital. I know in the hospital, usually the blood pressure runs high because they say like stress and all these news factors. But at least in the clinic, you can make sure that they are sitting for 5 minutes, no cross legs, at the level of the, arm, they're checking the blood pressures. These are very important things to see. Okay, inspection. What would you see on the inspection? What do you want to see?
Sweating, like leaning forward.
Okay, okay, leaning forward, sweating. What else? Maybe some structural deformities. Yeah. Sorry.
The surgical scars.
Yeah, surgical scars. Maybe erythema. You can see, right? All these things. Any drainage, any recent surgeries, like scars that can tell us about like surgeries. Maybe deformities that can be associated with like marfans, all these things we look in the inspection part. Maybe you can also see there's like they call parasternal heave that you can see in conditions. Okay, so all these things are very, very important. Okay, maybe trauma. Patient came to the ED, does not remember what happened at home, fell maybe. So there's a trauma you can see. Okay, yeah.
And also, don't forget to look for vesicular lesions and a dermatomal pattern, which can give you chest pain, and it's not cardiac, it's softer.
Yeah, and even it can happen before the lesions appear. But again, if they're like lesions in a pattern, like specific, you can pretty much say this is like likely because of the herpes. Okay. Other thing is palpation. Okay. What do you want to look at in palpation?
Pain reproducible.
Reproducible, which is costochondritis. What else?
with costochondritis, the pain is reproducible at the costochondrial
Mm.
junctions, not just anywhere, the costochondrial junctions.
What else would you look?
Fractures.
Huh?
Fracture and trauma.
Yeah, trauma, maybe flat chest, you can also see that more than 5 ribs, they say. You do like see if there's like, any change in the chest, wall. Pardon?
Predators.
Yes, capitus, maybe subcutaneous emphysema that can happen with, esophageal, rupture or injury. So these things you look at, okay, in the palpation part. Percussion. What do you guys think of percussion? What are you looking? Maybe, what do you think, like pneumothorax, what would you see? No, right? So it's like dullness in that area because of the fluid or maybe absence of the, because of the air that is causing the, like that's causing like a vacuum between the lungs and the chest wall. So it is also very important, especially in diagnosing these pulmonary conditions, okay? Auscultation. Any idea about that? That sounds, we want to see like it's like in all the, usually we do like six like 6 areas of the chest we usually look, okay? We have to make sure that there's like no vesicular rhonchi that can tell us about like maybe pulmonary origin. If there's like a new murmur, what do you guys think? Could be MI. So we have to be very careful about that part too, okay?
I'm sorry, particularly if it's a new MR.
Yeah, new
murmur,
MR.
You have to think about polytendony rupture or the papillary muscle ischemia
Yeah.
with inferior.
Yeah, again, most of the time you are not sure this is new or this is old, but at least if you have that finding and you can ask the patient if this is something new, they've never heard of this murmur in their history, like you can simply say that this could be new, and then you have to do further workup regarding that, okay? So
Also, pericardial friction.
yeah, pericardial friction rub is very important. Differentials.
And I would just say, take your time with the cardiac exam,
Yeah,
because if you're going too fast,
yeah,
you're going to miss the sounds.
yes, definitely. Yeah. Look for all the four areas, which is like second intercostal space on the right side, left side, the fourth intercostal space just along the sternal border and also in the apex area. What are the differentials if you look for the cardiac origin? ACS we can say, which is acute coronary syndrome. There are like 3 diagnoses that comes under ACS, and they are very important. First one is unstable angina. Yeah, unstable angina comes in acute coronary syndrome.
And
Se- STEMI and STEMI, yeah. Non-ST elevation MI is the second one, and the third one is STEMI. Okay. What else can you think of cardiac origin? We just discussed pericarditis. Yeah, is that anything else? Myocarditis is very important. Okay. Endocarditis. Okay. All right. And that can help like in the physical exam. You can see like because of the myocarditis, there's like a new onset heart failure. So you can see like JVD, pulmonary congestion, a peripheral like edema. So all these things are very important. Okay. What about vascular? What do you guys think? What is like most common thing that you can see on the vascular side? Huh? Dissection. Aortic dissection we saw, right? Okay, it's very important in the chest. We have to see is like type A, type B, you know.
Like in the mind.
Yeah, definitely. So it can present as MI. Then what about pulmonary origins? What are the common differentials? PE, pneumonia. What else? Huh? Yeah. Pleuritis, pneumonia, PE, all these things are the common pulmonary differentials that we can think of. Okay. Maybe pleural effusion. We have to see, okay, what is happening. Gastrointestinal. GERD is very common. Spasm is very important. Esophageal spasm, ulcers. Okay. Anything else? Yeah. cholecystitis. You said like esophageal rupture, very important, especially if they have like a lot of alcohol, binge drinking, vomiting. That can also cause Mallory's, tears. So we have to be careful about that part. Musculoskeletal costochondritis is one of the common, okay, inflammation or infection, okay. Psychological, anxiety, panic. So maybe like somatic, syndromes. And I would tell you, we have often seen that the patients come to the hospital, they say, I have chest pain. Because it's very common, we say, okay, we have chest pain, they say yes, and then we don't ask about other symptoms, okay? So in these patients, you will see like chest pain, abdominal pain, all over the body. There's like soreness, okay? They have usually PTSD, bipolar disorder, maybe depression, anxiety. So we have to be careful about that part.
You always have to rule out organic etiology in those patients who present with symptoms that you think it's psychological.
Yeah.
You have to rule out organic etiology, right?
Okay. All right. So infectious, again, it could be maybe abscess, maybe again, women's can be mastitis, can be a pacemaker or ICD infection. Okay, these are the common things we have to look. Okay, or myocarditis. Again, we discussed that in the cardiac differential.
And in cardiac, don't forget valvular heart disease. We talked about MR. Also think about aortic stenosis because they can present with angina,
Yeah.
right? First, and then always think about tachyarrhythmias with cardiac.
Yeah, this is very important, especially in the elderly people, unless they have like bicuspid aortic valve or there's another syndrome. I forgot the name. With the web, what's it called? Turner. Yeah, in Turner syndrome, they can have like usually the bicuspid aortic valve. They can present earlier, like, okay, but usually in people who are above 60 or 65 age, they can present with aortic stenosis and angina, syncope. These are the very common symptoms associated with the aortic stenosis.
Turners can also have coarctation and bleeding
Yeah.
as well.
Definitely, yeah. So investigations. ECG is the most important thing. And then they say when the patient presents in the ED, and you think like this chest pain is because of the MI or something. What do you guys, within how many minutes you have to get this EKG? Recommended 10 minutes. Yeah, you have to get EKG within 10 minutes. Okay. Biomarkers. What do you mean by troponins? Okay. High sensitivity, they call nowadays. Troponins are very important. 0, 1, and 3 hours. Okay. So it's like 3. And it should be stat, both things. Everything should be like mostly stat in this case. Okay. Unless there is like low suspicion, then you have to do like regular one. Chest X-ray. We want to see maybe there's like a tamponade, maybe intestinal widening, pneumonia, all these things. I know, like they're like findings even with the PE you can see on the X-ray with the Hampton. Yeah, Hampton's hump. You can see. Yeah, Western Mark sign. You can see that on the chest X-ray. So these are the small things that you can see on the chest X-ray, and that can also help you with the diagnosis. TT is very important.
Okay, wait, the chest X-ray, sorry, you can also see like a pneumomediastinum,
Yeah.
like you might see with esophageal rupture or pneumomediastinum. You can also see with PCJ,
Yeah.
pneumonia as well.
Yeah, pneumothorax, pleural effusion, apart from the rest, like infection, etiology, maybe hemothorax, all these things you have to look on the EKG. And at some point, we might give you an idea how to like read the chest X-ray, like trachea should be central, all the rays, whether like good inspiratory effort or not, all the things we have to look.
And with co-op, you can see the figure 3 sign on chest X-ray. You can also see the ribbing, on
Notching of the ribs.
you can also see the notching
Yeah,
of
so
the ribs with co-op.
yeah, with aortic coarctation, you can see on chest X-ray specifically, there's like a sign of they call 3 figure. You can see that. That can also help. With the TTE is transthoracic, the normal echo we order. It should be like a complete transthoracic echocardiogram. Usually we look for the valvular, problems, could be MR, tricuspid involvement, aortic involvement, just to get an idea, okay? I know we can do like further workup later, but these are like common things. Maybe there's like a RV dysfunction or left ventricle dysfunction. You can look like basal hypokinesis, maybe Takotsubo type picture, cardiomyopathy, you know?
Anterior with the inferior apical ischemia with
Yeah.
Takotsubo, so stress induced cardio.
Yeah, definitely. You can see like there is like left ventricle hypertrophy, or maybe all the chambers are dilated. So these all these things we are looking on the chest, sorry, the TTE, just to diagnose. Maybe you can see some problem with this. If there is like aortic dissection, you can see some findings on the echo too. Okay, so you have to be very, uh, like you can. I would say it's. I know like only at that moment you can evaluate the heart, but it can tell you a lot of things with regarding the uh, valve, how they're working, muscle. Is there any issue specifically, general like diffuse, or is like a specific segment of the heart is involved? The other thing is the CT chest, and it can tell us about again. Uh, Whether there's like honeycombing, very detailed things. It can tell pleural effusion, whether there's like infectious etiology, atelectasis. It can tell us whether there's like any aortic dilatation, dissection.
And sometimes you might have been doing a CT just for another diagnosis, like incidental low-dose screening for lung cancer, kidney, pneumonia. But when you look at your images, you look at the coronaries for calcification.
Yes.
And you can determine risk for coronary artery disease.
Yeah.
Sometimes the radiologist will also, in their detailed report, say evidence of coronary calcification.
Yeah, definitely. And I think you'll see also nowadays they're doing the calcium scoring to determine whether the patient should be started on any statins or not, which is very like it's becoming more and more common nowadays. So the CT can be very helpful, especially when there's the the blockage or the is because of the calcium, because calcium you can see on the imaging, okay, on the radiation. So anatomic lesions you can find, okay, on that. The other thing is CT chest with PE protocol, which is pulmonary embolism. Sorry, protocol is like control. I don't know. It's a mistake, typo mistake. So, sorry.
So we do need to correlate that with the calcium scoring, because probably we won't consult cardiology for a low calcium score because we don't identify whether it's inside the coronary or outside.
So,
So what score should we be on the lookout for? Say maybe this patient might benefit also.
some
or-
concern.
or not.
So no, again, I think you're confused. The calcium scoring is only for the statins. Okay, whether it is like mostly done outpatient. This is not like inpatient thing. Okay, the the other thing is that if you see they mentioned, okay, there is like significant calcium deposition, likely occlusion, partial occlusion of the arteries, then you can consult cardiology. But also you have to be careful whether the patient has any symptoms or not. Imagine the patient is like completely fine, walking, no symptoms, and you are consulting cardiology. You can maybe do the uh, like stratification and maybe outpatient evaluation. Okay, so again, clinical picture is very important. Okay.
I have a question.
Yeah.
Along with the physical exam and some auscultation and palpation, we can check with the focus. Do we routinely using a focus in ED when we admit the patient for medicine, or something that we not usually do?
We highly recommend and encourage that you guys use focus as much as possible. As you can see a lot of things on like at least cardiac function. You can see whether there is like any uh, pneumothorax, okay, or maybe other findings. We are doing these what they call like the ACP modules.
ACV
Yeah,
modules.
modules
We
in the
have
clinic,
dedicated modules.
and you can see like how to evaluate the liver or the gallbladder, all these things. So I think if you mentioned in your round that I did focus on this patient, you can impress the pretty much attending. I know.
I think focus is more so helpful for looking to
Yeah.
see if there's heart failure,
Yeah.
or if there's a pericardial effusion. Like that's definitely helpful because that's one of the things that causes like chest pain, pneumothorax for sure.
Yeah.
But I mean, it's not gonna really help you with ECS.
Yeah.
It's just an EKG instrument.
Yeah. So again, if you're in the ED, you have like very little time. Again, if the patient has like becoming hypotensive and all these things, then you can do POCUS quickly and see while you have ordered the X-ray and sorry EKG, troponins and everything, and you have like POCUS, you can definitely check it. It will only take maybe 2-3 minutes or 1-2 minutes to evaluate the function.
Also, it can give you some idea in terms of pulmonary embolism if the patient is developing right ventricular strain or dilation, or
Yeah.
maybe, the lumen of the pulmonary artery in itself.
Because in that case, RV
Yes.
would be bigger than the LV. Okay, the right ventricle would be bigger than the left ventricle, which means there is significant blockage, maybe the saddle embolism, or maybe one of the main arteries in the of the pulmonary is involved. So we have to do something. Okay, like vascular surgery consult.
Also, just referring to Dali's question. So in terms of calcium scoring, that CT protocol is completely
Yeah.
different than the one we do
Yeah.
for the coronaries. The one we do for the coronary intraluminal obstruction, that is coronary CT angiogram.
CT
That is a
angiogram.
completely different study. That is performed sometimes in the ED, or maybe, cardiology performs it if they're not planning to do any invasive testing right away. But calcium, scoring is kind of an outpatient procedure that is not done. It also doesn't evaluate the intraluminal thrombus, just
Yeah.
the luminal calcification
Yeah.
to stratify how much risk they have.
Yeah. So I think again, this like chest pain, we are focusing what to do in the ED or in the inpatient when the patient presents with the chest pain, and we are ruling out the most common life-threatening conditions. The one we are talking about, the calcium scoring, the other things, these are like more of outpatient things we are doing. Okay, we never do workup for like statins in the hospitals. Okay, we do like acute things, which is happening, we can fix. So cardiac MRI, it's not like something that I have seen in the ED, but again, you can do that to evaluate further. Maybe when the patient is admitted in the hospital, and usually the cardiologist, they have to order this thing when they think that they have to maybe the um, cardiac hypertrophy or cardiomyopathy is involving, maybe amyloidosis, all these conditions. Then they can, yeah, sarcoidosis. Then they can order that cardiac MRI. Okay. So next few slides, I would just show how to order these common things, so that you guys are comfortable. Okay. So first thing is EKG. You type like ECG 12 leads. Okay, you have to select that part, and then if it will show up or pop up this thing, and you have to do stat once, and then you can mention the reason chest pain. If the patient has any congenital heart condition, something you can mention, because that way they know what to see. And it helps, especially when the cardiologist is interpreting this EKG. Next thing is high sensitivity troponins. Again, is 0, 1, and 3 hours panel. You have to select this one. Okay. Otherwise, they will do only one time, and then you don't know. You're waiting for 2 hours, and there is no troponin levels ordered. Okay. So you go like stat today, and venous blood is okay. Chest X-ray. You can do routine or stat depending on the presentation. Stat is also fine if you're in the ED. Okay, completely fine, because it's not like a CT or MRI, which is a big thing. And then you can type chest pain. You can also describe something else in the reason for exam. Free text, you can type anything, whatever you think, and that would help the radiologist in interpretation of the imaging.
We need kind of.
Coming back to chest X-ray, I'll show you one thing. There is an option called portable. Can you see that? Yes or no? Most
Yes,
of the times I do portables because portables are quick. The machine will come to you in like within half an hour and they'll do it. And then you can get the images. If you don't do portable, you have to wait for the transportation, which can take like 5 hours. It may never happen. So I think that option, what I will do is those orders you put as your favorites. So they all have it like under your favorites. So usually most of the orders in the inpatients are portable.
Okay.
It's better. Unless you want to do 2 views, like AP lateral view to look for any consolidation, tumor, mass. It's better to select portable. Yes.
Okay.
Any KUB, if you want to look for abdominal, pain, if you want to get an X-ray quick, I usually select the portable. Yes. Yeah.
Okay. Yes.
And the other thing too is, remember, we're working as a team, and so the radiologists do like, I don't know, 500, 1,000 X-ray, chest X-rays. They do so many orders of chest X-ray.
Yes.
And when you give them the reason for consults,
Yes.
It helps them to be very specific in what they're looking for, so they can zone in for certain things.
Yeah. So again, if you mention fever, cough, they are looking for infectious etiology. Okay. Chest pain, again, looking for major things like tamponade, aortic, mediastinum widening, all these things. If you look, maybe decrease sound, like breath sound on the right side, they might find pneumothorax or maybe fluid diffusion. Okay, so it's very important what you type in the uh, exam reason, and I think it will only take 30 seconds or 1 minute to describe.
If you
So
don't find the reason, you can do other, and then you free text it. Reason for exam. Can you see the reason for exam?
yeah, the free text, right? Yeah.
Any question about chest X-ray? If we order in stat portable, do we need like a page imaging to the
No.
someone come or
No, no,
not?
no,
like
you
that?
don't have to. Yeah.
Usually, most of the time happen within 30 minutes, but if they don't come, you just need to call X-ray radiology department.
Okay.
They usually bring some technician right away.
All right. Thank you, Dr. Kumara. So, echo. So you would type TTE and then it will show like transthoracic complete. Select the complete one because this way we can, like, the cardiologist will be able to like see all the, I think it depends on the how the technician is getting the imaging of the heart. So I would say go for the TTE and do it stat as per patient presentation. Then again, in the reason for exam, you can specify shortness of breath, endocarditis, all these things, or you can even say others, and then you can type whatever patient is complaining of. Okay. Will this procedure be performed at bedside? Yes. Usually I put do yes, and then they can do it. Okay. I don't think so. There's like a difference between doing in the specific area or maybe at bedside. It's same thing. Okay. Special request. Usually it's NA, like not applicable, but you can do like agitated, but that's like in a different condition when they are evaluating for PFO. Again, it depends. What
What
protocol?
for stroke?
Huh?
Stroke rule out?
Yeah, stroke rule out. Like whenever the patient has ischemic stroke, ischemic most commonly, they are looking for embolism. Okay, and the embolism can happen in the brain because of the plaque rupture. It can happen in the carotid artery. It can happen from the atrial fibrillation, LV thrombus, or there can be a defect in the interseptum, like in the septum, PFO, and which is very common in the young people. And you would also hear about this rope score. They calculate, yeah, and to see to evaluate further because it can happen. Okay. So that is, and then you can say, is the tech authorized to use echo contrast? Yes, most of the time, unless there is contraindication. And then in the performing or interpreting provider, you can put the on-call cardiologist or whoever is available, their name, okay? And then that will also be helpful, like in case they do the imaging and it's been like more than 5 hours, 6 hours, patient, we have to decide whether the patient is staying, going. You can call or sorry, text the cardiologist and let them know, can you please provide your recommendations? And then they will tell you what to do, okay?
Generally, the interpreting provider is always the cardiology on the
Well,
consult. You
yeah.
put the same cardiologist.
Yeah.
Because they are the ones who is going to see the patient. They can see the images.
Yeah. So if there's like a cardiologist who saw this patient in previous hospitalization or in this hospitalization, you can put their name. You should put their name, okay? So that will be otherwise.
Do you have to check cardiology who is on call for the week or no?
It is.
We have a
Yeah.
list that comes every week. A cardiology on call. If the patient is an assigned cardiologist, we use on call.
Yes.
The patient is already known to one cardiologist. You just need to put their names. Yeah.
All right. Yes.
So
So
if the patient belongs to Dr. Abela, put his name. If the patient belongs to Armenius, put her name. You know.
yeah. All right. So CT chest again, it's like you can start. You can do contrast. Reason for exam. Everything is same. Okay. CT angio chest, again, it will show CT angio chest PE protocol. Okay, you have to select this one. And then if you go here, again, it's done with the IV contrast, reason, and then yeah, that's pretty much it. I have never selected this anesthesia, sedation, or no anesthesia, and I don't think so you will encounter the same thing unless the patient is very agitated or something. Then you can do like maybe small dose of Xanax or
So you
some,
don't have to fill any of those things.
yeah, mostly,
The order will still go to you.
yeah. So unless there is like a red, asterisk, and then some, you have to select something specific. Okay. So what do you guys think when you get like um, a page for new admission from ED, or maybe a text from on the Epic from nurse or someone? What is the most like how would like you communicate with them for the chest pain? What would you ask? Huh?
When it started,
Yes,
how,
Yeah.
how significant is it?
Stable,
Yeah.
stable.
And ask to take vitals
Yes.
and come to assess the patient.
Yes. Yeah. You can say like if it's like ED physician, you can simply say, hey, okay, when did the pain started? How was the presentation? They will typically tell you without you asking. They will tell you, hey, this patient presented with this pain, and we did this thing, which is very important. Then they can tell you, oh, the patient is widely stable or maybe hypotensive. They can tell you what they are doing for that. Lab reviews, like you would review the vitals and the labs while before calling the patient, like the ED physician, or maybe while you're talking, you can also review. Okay. And then I will show you a section how to go and compare the new labs and EKGs with the old ones, if applicable, which means if the patient has previous EKG and troponin levels available, we can compare. And then also you can see on the uh, orders, you can see what has been ordered, like aspirin, clopidogrel, heparin, what did they do like in the ED, so that you don't duplicate the same treatment, okay? So if you go, usually you are in the summary, maybe notes part of this tab, okay? But if you look on the left side, there's like chart review section. You click on that, and they're like multiple, again, small like tabs. Sorry, you can say headers. Yeah. So my favorite one is cardiology because I like it. So they're like EKGs available from 2025, I think 2, 3, yeah, and also from 2024. So that way you can compare the both EKGs and see if this bundle branch block or this new like T wave inversion is new, is it old? So it is very, very important. Okay. If EKG is similar to the prior ones, I'm not that much worried. Okay. Again, echo, you can see if you are looking for the labs, you can click on the lab section and imaging, which will show you about the CT scan. Okay. Acute coronary syndrome. As I said, there are like three conditions we are looking: unstable angina, NSTEMI, and STEMI. If you look at the NSTEMI and unstable angina, the only difference is the troponins. Okay, if the troponins are elevated, it's NSTEMI. If it's normal, then it's unstable angina. Okay, again, T wave inversion, ST depressions, pretty much can happen with both. Usually I was studying and they said like with now high sensitivity troponins, the unstable angina is not very common. Okay, usually they diagnose the patient with NSTEMI. That's what they were like saying. Literature review, and you can see this like partial occlusion of the artery. It's not completely occluded. That's why you see ST depression rather than ST elevations. And on the right side, there's like STEMI, which is complete obstruction. It can happen because of the plaque rupture. It can happen because of the embolism. Anything that can cause the platelet aggregation and the like the coagulation factors to make a clot. ST elevation that usually happens, and based on where the findings are, you can diagnose. You can pretty much say which artery is involved. Troponins are always elevated. One thing is that repeat troponins can go up or down depending whether the reperfusion has happened or not. Okay, imagine the initial drops are very high, but now it's downtrending. But the downtrend is significant. It could be because the blockage has been resolved. Okay, or maybe it is getting worse, and then you will see the troponins are getting high and high. Okay, so it can go either way. If there's like patient has chest pain, STEMI, drops can go up and down. Okay, usually they are elevated. One other thing is that if the chest pain has just started, drops can be normal. So STEMI, like the ST elevation itself is like emergency. Okay, activate the cath lab. That is okay. Next slide. Okay, I'm gonna like in the next few slides, I'm gonna talk about heart score, TIMI score, and GRACE score. And why is it important? Because it can help you in discharging, admitting, in the observation or in the inpatient. You can find this calculator on the MD Calc. And the reason is that heart score is usually when you are suspecting ACS, okay? You have not diagnosed ACS, you are suspecting. So it is usually done in the ED. You will see it involves five things: history. Again, you can see like it's moderately, slightly, or highly suspicious, EKG findings, age, risk factors, initial troponins. Okay. Based on those, you can stratify the patients: low, which is 0 to 3, 4 to 6 is intermediate, and 7 to 10 is high. Okay. So if heart score is low, you can pretty much confidently say, okay, it's less likely ACS. And if the serial EKGs and troponins are normal, not changing, it means you can pretty much safely discharge the patient. For intermediate, you can admit and you can do further cardiac workup. Could be stress echo, could be imaging to see the coronary arteries, and sometimes they can do maybe invasive like coronary catheterization. Okay. High, usually they admit ACS treatment and then early invasive strategy, which can usually happens within 24 hours or within 72 hours. Okay.
So that you guys have to understand that with the intermediate, you place the patient in observation. You don't admit to inpatient. If they're high heart score, then you admit to inpatient when you're doing the initial.
And again, this is what you do in the ED. Okay. When you are suspecting ACS. Once you have diagnosed ACS, usually we don't use a heart score. It's a different score. Okay. TIMI score is very common. It is used like it involves 7 factors, as you can see: age, CAD factors, aspirin use, angina, ST changes, and all these things. And then you stratify the patient based on 0 to 2 is low, observation serial EKGs, because now you have diagnosed the patient with like NSTEMI, okay, or unstable angina. So you have to do like workup. Okay. Intermediate is like you admit and ACS therapy, and I will tell you what is ACS therapy. Early angiography, 5 to 7 is high, you admit, and early invasive strategy, which is within 24 hours usually. And if it's really high risk, then they can even do within 2 hours. Okay. Gray score is another. If the patient has like NSTEMI or STEMI, they can stratify the patients. 109, less than that, low risk. 109 to 140 is early angiography, and if above 140 is like within 24 hours. Even immediate if it's unstable, which can be like low blood pressure, shock, all these things. So now coming to the case, this is like a patient, 68-year-old man, came to the ED for 30-minute history of retrosternal pressure like chest pain that began while climbing on stairs. The pain radius to the left shoulder and jaw and is associated with diaphoresis and dyspnea. Over the past week, he has experienced several episodes occurring with progressively less exertion, but today's pain persists despite rest. Past medical history is hypertension, diabetes, hyperlipidemia, CAD with prior PCI. So you did the vitals showed slight hypertension, maybe like the respiratory rate is 22, on room air, a physical exam, intact, alert oriented, mild apheresis, normal heart physical exam, no heart failure. Okay. You did the investigations, 12 lead EKG, troponins, CBC, CMP are very common, glucose, and the chest X-ray. And then these are the like results. What do you guys think? Hmm? Okay, T-wave inversions. Can you specify? Yeah. Okay. So if you look like this is pretty regular on the rhythm strip, you can see it's like regular RR interval, P followed by QRS followed by T waves. But if you look at the V5, V6, there's like some T wave inversion, some concern for like ST depression. If you look at the troponins, it's like 8, initial one that is like 12, 10, and then again 8 within normal range. Okay. And chest X-ray was unremarkable. So what do you guys think? Patient has chest pain and normal troponins and ST changes. What is the unstable angina? Yes, that is correct. What is the management of unstable angina? Anyone? Okay, anticoagulation. That is also, yeah, part of what else? Yeah, depending on heart score. What else? What are the common like antiplatelets that we use? Okay, yeah, yes. So if you look at the vitals, if the oxygen is less than, like saturation is less than 90, you can do oxygen supplementation. It's like 90, not 94. I was looking. Nitroglycerin is very important. The dose is like 0.3 to 0.4 milligram tablet, which is sublingual. You give it and you can repeat that every 5 minutes. Okay, 3 times. If the pain resolves, good. If the patient still has the pain, then you can start the patient on nitroglycerin drip at the rate of 5 to 10. Okay, and then you can increase gradually every 3 minutes, I guess. There's an auto set I will show. The other thing is aspirin. Loading dose is 325 that you give. High dose statin, anticoagulation, which is usually heparin. Beta blockers are given usually within 24 hours unless there is a contraindication. You can admit and do further workup based on risk stratification. Okay, and then P2Y2 like inhibitors, which is like clopidogrel, prasugrel, and ticagrelor. Again, this is done if the patient has high risk, and I will tell you why we don't do the clopidogrel right away. There is a reason behind it. Imagine the patient has like a chest pain, and you do aspirin and clopidogrel, and during the angiography, they found the patient has multi-vessel involvement, or maybe the lesions are not amenable to PCI. They're going to go for cabbage, right? But if you have given clopidogrel at the like initial, you have to wait for 5 days, okay? Because the cardiothoracic surgeon, they don't touch the patient, okay? So it is very important. So at least you can do nitroglycerin like aspirin, statins, heparin, because heparin would go easily. And then clopidogrel, you can talk to cardiologist, okay? And cardiology consult. So that's how you do it. The other thing is that you have to be careful with the contraindications of these P2Y12 inhibitors. Like I was reading, prasugrel is contraindicated if the patient has stroke history or, uh, you know, uh, or TIA, and you don't do the prasugrel until the patient that they decide that they have to place a stent. The reason is that it is again associated with bleeding, especially with the cabbage surgery. Okay, so you have to be mindful of these things too. Case 2 is a 68-year-old man, again in the ED, 30 minutes of retrosternal pressure like chest pain while climbing stairs, left shoulder and jaw radiation, diaphoresis, shortness of breath, and it is like several similar episodes that over the preceding week, okay? Hypertension, type 2 diabetes mellitus, again, hyperlipidemia, same condition, and CAD history. These are the EKG and troponins. And the normal troponins upper range is 14. So what do you guys think of this? And STEMI, because there is no ST elevation. If you look, there's like V4, V5, V6, there's like some depression, T wave changes. Again, the 2 and 3 lead, you can see that. So this is like also in the AVFs is like T wave inversion. So this is like NSTEMI. And which score do you use in the NSTEMI? TIMI and what? Grace, yeah. Okay.
So based on looking at the EKG, where do you think is a coronary artery? Which coronary artery is involved? What do you think? Yes.
So
Inferior is which coronary artery? Yeah, right.
Yeah.
You already know based on EKG.
Yes. Okay.
I can't see from here, was there any AV block or anything?
No.
Thinking
No, because it's the PR interval is less than 200, not a big block. So, okay.
Why
Yeah.
Dr. Ramsakar asking for the AV block, the RCA? Huh? Yeah, it supplies the AV node. One of the branch of the right coronary artery goes to the AV node. So if that branch is involved, you get complete AV block.
Okay. So management is pretty much same. Oxygen supplementation is saturation is low, nitroglycerin, aspirin. Again, P2 Y12 inhibitors, but you have to talk to the cardiology about that.
The best time to do P2 Y12 inhibitors is in the cath lab. If they see a big blockage,
Yes.
like 80-90%, before they put a stent, the loop, then they give Plavix. They
Yeah.
call us loading dose.
Yes.
Because most of the patients, when they're in cath lab, they're still awake.
Yeah.
So they give a loading dose of 600. It's a big dose, right?
Yes.
Almost like. Then they know that there's only one artery involved. So they're not going for cabbage, they're getting a stent. So they can do Plavix. Along with, they can do GP2B3 inhibitors like apixaban, tirofiban, those things.
Yeah.
One other thing is that you want to avoid nitroglycerin, RCA.
So yes, definitely. So common like contraindications are like RCA, cardiogenic shock when it's like right side involvement. So recent use of PDE. Yeah. So you have to again, they're like contraindications for everything. Imagine if the patient has like hemoglobin of 7.5 with prior like hemorrhagic stroke history or significant GI bleed, family history. You have to be careful with the IV heparin too, okay? Because you have to make sure that you are not harming the patient. You are actually helping the patient, okay? But that's like more of like complex patients that I don't want to discuss right now because it will like complicate things that you will see with the exposure in the cardiology or in the floors. So you will learn more about that, okay?
If you have questions, you ask your residents, and if they have questions, they ask the attendings and cardiology. We're here to help you, so you don't have to do things by yourself.
Yes, yeah, definitely. So high dose statins, they're like two. One is atorvastatin, which is 80 milligram, and other one is, rosuvastatin, which is 40 milligram, okay? High dose. You do like for NSTEMI, you admit the patient, cardiology consultation, they do the TIMI score, and then they like to do the early angiography. Usually within 24 hours, they do that, okay? Next patient. Yes.
I have a question about that. So if in the ED and STEMI or STEMI, we're getting called to admit the patient and then we consult cardiology or cardiology?
So this is textbook thing. Usually
Okay.
when they say NSTEMI,
They're
they will
good.
just let you know that hey, they have ordered the aspirin,
Okay.
all these things. They have consulted cardiology, patient is on heparin, and then say a patient is going for the cath lab or maybe in this,
Okay.
PCU. So that's how you will
Okay.
see, okay?
Thank you.
Yeah. Because they have to rule out all the major things before they admit or discharge the patient from the ED, okay? This is when if you are in the ED doing the ED rotation, then that's a different thing, and you can consult cardiology. 62-year-old male, which is presenting to the ED, 45 minutes of severe crushing retrosternal chest pain, which happened suddenly while moving his lawn and mowing. Okay. The pain radiates to the left arm and jaw associated with sweating, nausea, and shortness of breath. Is persistent, not relieved with the rest. Past medical history is pretty much same, just like the previous hypertension, type 2 diabetes mellitus, and hyperlipidemia. These are the vitals: afebrile on room air, slightly tachycardic and slightly hypertensive, alert. Physical exam is unremarkable. These are the findings. What do you guys think?
STEMI.
STEMI. Provenance went from 30 to 90 to 210. Okay. So I don't think that you have to wait for the 210. It was like 3 hours. And what is like the door to balloon time?
90 minutes.
90 minutes. But if there's like the facility is not PCI capable, then what is the limit?
120.
120. So 2 hours. Okay. And imagine that they are unable to get to that facility even after 2 hours. What would you do most likely? Yeah. Yes. Huh? Yeah, streptokinase, specific therapy, fibrinolysis basically. Okay. So management.
So wait, go back to in respect for Dr. Bumala, tell us where the lesion is.
V2, V3, AVF, V2, V3, right?
Yeah.
Okay, V1, V2, V3, right?
Yes. All the reasons. LAD. Yeah.
So
That's
where do
yeah.
you think the lesion is?
Google involves.
Or lesions?
Yeah, and LAD.
Huh?
Yeah, multiple like vessels involved.
So what vessel?
So this is not like actual patient EKG. This is not actual EKG. So that's why like, but just wanted to show you the ST elevation. if it's like in the anterior leads, which is V1 to V4, right? Or V2 to V4. Yeah. If it even is there like a one, two, sorry, 1 millimeter ST elevation is significant, but in the rest, you it's like should be 2 millimeter again, and it changes with the female and male criteria. Okay. But yeah, these are like ST elevations. And then next thing is, what do you do? ST elevation, you would hear cath lab, cath lab, yes. Activate the cath lab, aspirin, again, clopidogrel, depends whether you're doing anything specific, PCI or surgery. IV heparin is important. I will show you the order set, how to order it, intensity statins, because you want to like target all the things. What happened actually, plaque rupture, so you have to stop the, do the statins to stop it. Platelets and coagulation factors are involved, so you have to do both the antiplatelet and the anticoagulation to stop the whole process. Okay, and nitroglycerin to relieve the symptoms. Okay, so it's very important, and to avoid this like any ischemia, you do oxygen supplementation if it's less than 90%. Stat cardiology consult, and I would say if you see STEMI, call the cardiologist. Hey, this is the finding, and so that they know. You cannot simply put the consult stat for STEMI and then you sit behind. No.
Even for any consult which is stat, you have to call them.
Yeah,
If you don't
stat.
get it. You have to call them when you're putting stat.
Yeah.
So, in that patient with that EKG, not hopping on the EKG, it's most likely multi-vessel, anterior, B1, B2. You're looking at LED, then there was some 2, 3 and AVF, if I see this, so you're looking at imperial, you're looking at RCA, so you're looking at multi-vessel, so chances are that patient is going to go to CABG, so just hold off on the P2 white inhibitor until you go to cardiology. You know, just use a little common sense.
Yeah, and there's one thing else. There's like G2B and 3A inhibitors, which is tirofiban, and one is like is the IV therapy, and they can do that with aspirin before even going to the cath lab. And once in the cath lab, if they decide going for the CABG, they can pretty much stop it. The half-life is not that long, just like clopidogrel. So again, you will see that in the cardiology unit, things change a lot. Okay. Case 4, again, this is the last case, sorry. And this is, I know this patient because it happened 2 weeks ago. 51-year-old female. I got like a page for admission call. They said like patient has chest pain, nausea, some difficulty breathing, so shortness of breath. They didn't mention about the 2 months pain. They said like the EKG is normal, trops are normal, but we should maybe consult cardiology. I said like, okay, if you think you can consult cardiology, although they didn't consult cardiology anyway. I went, asked the patient. Patient said, I have this pain in the chest. I was like, okay, where does it stays here? I don't know. I have also back pain, all these things. I asked more. Patient has psychiatric history, bipolar, anxiety, depression, you name it. She had PTSD.
And remember, for women, they can present atypically, they can have nausea, they can have exertional dyspnea as an anginal equivalent.
Yeah, definitely. Yeah.
Abdominal pain, yes.
Definitely. So EKG pretty much normal, as you can see, regular PQRS, waves, no ST elevation, depressions. Troponins were normal, 11, 9, and 8. Chest X-ray unremarkable. So in this case, calculate the heart score if it's low risk. You can do serial EKGs. The patient still complains of the chest pain and you are worried about serial EKGs is fine, which can happen within 30 minutes. You can repeat the EKG. You can do like maybe later like troponins just to see if there's like you think the patient still have chest pain, atypical. Address the underlying conditions. So I found out the patient was on pain medications before, so you have to start the pain medications. She gets better. So yeah. Again, this is the order set. I have never used it because I never diagnosed STEMI in the floor. This usually happens in the ED or maybe before coming to the ED. So you can see you put like acute myocardial infarction admission order set. There's like pretty much anticoagulation, antilipidemic, antiplatelets. Everything is there. You just select it and you can start. Even with the nitrates, you can select it's sublingual. It also includes the IV, so you can modify it. Okay. The other thing is heparin. You type the heparin, and on the second you can see heparin ACS/AFib. You select this one, show like this. Okay. So it was like a very long order set. So I just took a picture of the main slide. You can see you can select anti-XA. I think our hospital is usually goes with the anti-10A factor. You select that, and then you do the bolus, which is 16 units per kilogram, and multiply with the weight. And then after that, you do the infusion and maintenance. Okay, and then again they calculate. They repeat this anti-XA, and then they decide how much to give the repeat bolus or the dosing. The maintenance dose is usually it's showing like 25 units, but up to date saying 12 units per kg. Okay, so again, the pharmacy will be there. They will be guiding, because on the heparin drip they usually guide you with everything. Okay, if it's like above therapeutic range or below therapeutic range, they will let you know. So key takeaways are like we have to rule out the life-threatening causes. Early EKG and serial drops are very important. Risk stratification with the heart score in the ED, and TIMI and GRACE score once they are diagnosed with the NSTEMI are very helpful, so that you can decide what to do next. STEMI is immediate reperfusion, so cath lab. NSTEMI and unstable angina guide again. You do the therapy, which is aspirin and anticoagulation statins, and then you decide whether you do further imaging or invasive procedure, and then treat the patient, not the EKG or troponin allowance. So again, the last case, patient had chest pain. You rule out everything and then you treat the patient. Okay. Any questions?
One more comment, guys. With the last patient, you can ask them if you're thinking it's non-cardiac, right? And non-emergency GI or home or something else, right? If you're thinking it's underlying psychological, you can ask them, how long did the chest pain last? There's a nice mix-up question where the chest pain lasted 3 hours, and after the 3 hours, you checked an EKG, you checked anytime under 3 hours, you checked an EKG, you checked strokes, and they were negative. If it's negative EKG cardiac enzymes after 3 hours, it is not cardiac. Okay, so ask for the duration.
Yes. All right. Questions?
I have a question. We're on the floor. Patients like I have chest pain, we order an EKG, we see a STEMI. Who do we call? How do we call? Or
I
we
would
do
say
a rapid response.
So if the patient has chest pain, STEMI, quickly open the chart. This is new finding. I would say if the senior is there, senior is there. Let the senior know, if not attending, that you are thinking this and you are ordering aspirin and all these things, and you are putting stat EKG, like the concern to the cardiology.
Calling cardiology.
Just in the first 3 months.
Call the senior.
Yeah.
When you guys will progress, you can kind of make.
Yeah. Senior or otherwise you can.
We have a STEMI on-call cardiologist 24/7 in this hospital.
Okay.
If you want to know who is on call, I usually call the ER. ER will tell you, hey, this Dr. Kapadia, Dr. Abela, you don't know. So you just need to call. And then what they usually do is they'll ask you to send an EKG to them.
Okay.
Because not all the STEMIs appears like a STEMI,
Mhm.
they may be artifact. So we have to show the EKG to him by text, and then they'll decide. They will activate the STEMI card.
Okay. Thank you.
And sometimes if you're waiting too long for things to happen, call an RRT, then you'll get help.
Okay. Thank
Rapid
you.
response.
Yeah, the rapid response, then you'll get help.
Yeah, no one will, punish you for calling RRT if you think the patient has something critical going on. Even if it's negative, that's fine.
Pay, it's a STEMI. That's.
Yeah.
First 3 months, ask your senior.
Oh, I see. Got it.
Is it a STEMI or is it a, looks like. But if the patient has crushing chest pain, something like that.
All right.
Thank you.
Okay, thank you. Thank you, everyone.
Thank you. Thank you.